Hello whānau, my name is Melissa Brazier and I work for Capital and Coast District Health Board here, and unfortunately I didn't get to stand as I believe possibly the only allied health representative in the room. Is there any other allied health sitting out there? Yay! So we've got a couple of other family members, that's awesome. I feel very honoured to have been invited to come here and co-present alongside Porirua Union and part of Te Ora Compass to talk to you about our community services integration program that we have at Capital and Coast District Health Board. So I'll just let Ioana and Simon introduce themselves.
Maloni, ko toku ingo ko Ioana, Viliamu Amusia. I'm from a general practice, and Simon and I will be chatting about our GP and our little story that has impacted in our community, and my role is clinical nurse coordinator. Cheers.
Tārofa lava, maro lava saifua, olo ingoa o Simon Saena. I am the general practitioner, clinical lead for healthcare homes for Porirua Union.
Lovely, and my clinical background by trade is a speech and language therapist, which my husband jokes just suits me perfectly because he can't shut me up sometimes. So Ioana has promised to give me a wee nudge if I go over my time limit. Oh yeah, it works. I was a bit worried about this from seeing things earlier. So we're here to talk about the community services integration, in particularly in Porirua Union, but also across the Capital and Coast District Health Board and with Te Ora Compass. So one of the things I think that for me working in clinically and then as a team leader for an older adults and rehabilitation community team has always been how do we bring a DHB community services which are working in the community space closely together with our primary care colleagues for good patient care and good proactive planning. And at Capital and Coast District Health Board, the vehicle that we do that with is our multidisciplinary team meetings, where we have CCDHB teams come and meet with the primary care practices to proactively plan. So what does this look like for us at Capital and Coast District Health Board and Te Ora Compass? So we have 34 practices ranging from Kapiti, who you heard before, right through into Wellington Central. And at each of those practices, they have MDTs either once a month or once every 2 months, where the community services teams from CCDHB come and support proactive discussion around patients. And the teams that we've surrounded these practices with is, one of them is my team, which is the Older Adults Rehabilitation and Allied Health. So that's a team with physios, speech and language therapists, social workers, geriatricians as part of that service. We also have the district nursing service that come along to those meetings as well. And more recently, we have had 2 more other groups join us. One is the Care Coordination Centre, which is the local NASC in Wellington, and Mary Potter, which is the Palliative Care Service. And I'm really pleased to say is that since we started in 2017, we have now had 380 multidisciplinary team meetings across the area. That has resulted in 1,140 case discussions for patients, resulting in better patient care. We have 80% of the population covered by our healthcare home practices. And the MDTs, I think for those of us that have been working in healthcare for a long time, this isn't new. Those of us that have been involved 20 years ago used to go to primary care practices and talk about patients. But this has been a way to formalise and support that and use that goodwill to keep going. So how do we do it? How do we build this MDT framework? It's very important that we develop relationships and trust and that we grow understanding of what we're all trying to do here. I think what is the most important thing in the world? He tangata, he tangata, he tangata. It's the people, it's the people, it's the people. It's the people that we serve, it's the patients that we serve, it's the people that work in our healthcare system across tertiary services and primary care services. And so getting those people together, giving them that shared goal, that shared focus of what are we trying to achieve by meeting together is better patient outcomes, better care for our patients getting the services that they need when they need it in the place that they need it. So quite lofty aspirations if you think about it. How do we go about doing this? Well, some of that is about getting the clinicians on the ground right at the very beginning to think, what could MDTs look like? What would work for community services? If in a DHB you have one community team with 34 practices, how does that team support those practices? A lot of the work was done in collaboration, and it's been a very exciting collaboration between CCDHB and Te Ora Campus, and I think everything that has happened in this community services integration space has been a really close knit between those two services, and we present very much a united front with how we work together. We developed a number of processes to make MDTs run smoothly, so everyone would understand how MDTs operate, who's going to do what, to ensure that they run smoothly. And of course a big part of it is meeting each other. So for every new practice that comes on board, we have clinical meet and greets with the community services and the practice to start developing that team feeling and that feeling of how they could work together. So what have been our enablers for successful integration? We've had quite a few enablers that have supported us on our journey. I think one of the big areas, being a community clinician myself and a team leader, has been the use of technology. So the community teams have been given iPads to allow them, when they go to MDT meetings at the practice, that they can access the DHB medical record systems and give real-time information about patients, not just about their services but other services the patient may be engaging, because we all know that sharing information between tertiary services and primary care services can be challenging at times. I think, as I touched on before, that absolute partnership approach, so that Te Ora Campus and CCDHB have been very, very strong partners in this and have worked collaboratively together. And with that is a big healthy dose of underlying goodwill. We all work in systems and processes that are imperfect at times, and when we bring clinicians together for MDTs, when we have GPs and practice nurses, DHB staff, we accept that there can be problems that occur at a higher level, but that the people coming to these MDTs are all there to work on patient care together and troubleshooting how to do that. The development of good guidelines is essential, so there is that understanding of how an MDT runs, what's the process to follow, and that's really essential when you have DHB services but 34 practices, because if you have 34 practices wanting to work in different ways, that can be quite challenging for the teams that are supporting. So from a lean principle, trying to keep that all streamlined is really important. All right, so on the back of that, I'm going to hand you over to Ioana, who will talk to you a little bit about how MDTs run in their area.
Thank you, Mel. From the DHB, we go to the heart of Wellington, which is Poriru and Cannons Creek, and we're in between Wellington City and with our previous speakers who spoke from Parapara Umu, we're in between there if you don't know Wellington at all. So this GP practice is a VRCA practice, which is a VRC practice which is low cost. We have just over 7,000 clients enrolled into this practice. While I'm trying to press this, I just want to give a big ups to Te Taia Whenua Heratonga, because I really enjoyed what you had to say. What I've enjoyed was about the nuka, so I'm hoping the nuka model that you use, so I'm hoping either Martin or my manager over there will send me to Alaska and so I can understand it more. So we're going to be chatting about the proactive care. Oh, geez, it's sensitive.
You don't need to press it at the TV, Ioana. You should be able to just hold it and press it anyway.
Back.
So we've got back, which is this one here. You should be able to just keep it here and just press that.
Okay.
That's back, and pressing that one will take it forward for you. Kapai.
Okay. Kapai. So just a little bit more about our practice. Oh, I can't see that one. I'll read that one. Just because I think it's important that you have a bit of an idea about our practice and who we are. So we have our clients, Pacifica 49%, refugee clients who are from Colombia, Myanmar and Syria. And we also have our Māori, which is 24%, and other is like Europeans like Russian or migrants, new migrants who are not under the... Yeah, we get a lot of new migrants coming into the area. So we have a really high, it's really important that we connect with the community, that you understand who's coming in, that you know, and that you have a relationship with them. So that was really important for us. Okay, here we are. So one of the things with the highlights for our healthcare home is the triage, because we used to, like similar to our other previous practice, we used to get 80 phone calls in the morning, and this was just in the morning, 60 to 80 phone calls in the morning, so the nurses were constantly doing a lot of phone calls and triaging. So this, with healthcare home, that has improved. Increasing in the patient portal, that was a really hard work. It's still not that high, but it's a work in progress. That was important for us to increase it because there were people who will be able to use it. We have a high young population, so they will be able to use it really well. And plus, a lot of people are sharing emails, so that was a bit difficult. So we're still working on improving that, but people are using it, which is awesome. We have good MDT rates. We basically took off with the MDTs, which is something that I lead. It was something that nurses are really good at because we do a lot of it when you work in hospitals. You do MDTs in hospitals and in mental health. So that was something that I thought, yeah, I can champion that one. The LEAN initiative has been really good, and I'll show you a couple of photos of that later. And we've worked on presentations, redirecting our clients going straight to A&M, which is similar to Wellington ED. So back to what I'm supposed to be talking about, which is the MDT meetings. So I chose specifically those photos because I thought it would be better to, because that's our staff. And it was important that the staff understood why we wanted to go healthcare home. And so if you just throw it in, because when you have, if you just throw it in, the staff won't understand, and they, so we needed to work with them. So one of the photos up there is the one that we did with Joe. So we did that lean, big, huge cleanup, and so that we had a fairly new office, but we still managed to get rid of a lot of junk that we didn't need, and that was hard work to get rid of it because everyone wanted to hold on to their own junk because a lot of the doctors have their own room and they were the worst ones as well. So we had to, really work with them. But our staff came along, and so as we worked together and doing after-hour stuff and being fed and looking after, and the management looking after them, you got to know each other a lot better, and they trusted us as well as you informed them and working together. The second photo was our staff being encouraged to go and do some outdoor activities together so that we get, it's like team building. And so that was a lot of our doctors and nurses and community workers and our own whānau. So, and letting our community know that we were willing to make some changes and that we're out there and this is us, so that we're out there in the community. People needed to see who we are more, because with GPs, you come to them. You don't do a lot, and because we're not a community, community as in you do a lot of programs out there. We're very much a GP practice where you come, make an appointment and you come there. So this is our team for the MDT. So the people who were really important in running this were the nurses, the doctors, the community workers and the cross-cultural worker. So our team, so we had a lot of, we've had 11 MDT meetings, 11 or 12. We get the care coordination team who could, what was important that was, as Mel had spoken about, that you had the little booklet. So I briefly read that really, really quickly, and but that helped us to get it moving. And also we had a meeting with the whole MDT community people because we hadn't really had a relationship with them. You don't really meet them, and so it was important for us to know who were the audit team, which is the older rehab people, who were the care coordination team, who was the social worker, and the other thing that we had done was I rung mental health and asked them to come because that was more important for us, that we had a relationship with mental health. They didn't really come along, but if you know who's in it and then you just chase them up and annoy them, somehow we got the psychiatrists, all three of them came with some of the nurses who I knew. So that went really well for us, and so we've had 2 separate MDT meetings with mental health. It's a work in progress. It's something that we need to work on, and it's something we want to strengthen because it's still really hard work working with mental health in the community. But otherwise, we work really well with the district nurses and the social worker who works within the audit team. Through them, we've managed to connect with Housing New Zealand, WINS. We work well with Health Literacy New Zealand as well, who do a lot with, they've helped to teach English to some of our refugee clients so they can get onto the digital stuff. Housing New Zealand was so important for us. Housing was a big impact. We needed someone who had the insight. And that was taking up a lot of our time as nurses, and so that was a time saver for nurses. And having a better relationship with our families, because you invite them, if they want to come to the MDT meetings. So the respite care, it was just a big plus, and that was something that we thought was really strong for our team. What's this? Yeah. So the enablers were we used the risk stratification. So through that is the Tūora Compass has a provider portal that we can access, and they use the top 5% and top 7%. And so sometimes you can choose those clients or the ones with the most classifications. And so we will choose those ones, or the ones who will send a message out to the doctors and the nurses and say who's on top, who is the most person that you think we can do some work with, and they would send names as well. We do year of care plans. We've tried the PIH, which is Partners in Health tool, with the pictorial pictures as well. We tried that, we sent it out. So we're constantly changing to adapt to our clients, and we had problems with that, so we've decided now to go and use something that a lot of people understand, and it's more patient focused, was Te Whare Tapawhā. So that's now in progress for us. We're looking at how we can improve. Youth health, the year of care plans, some people say, is youth health part of it? But for us it was important because there's teen suicide, pregnancy, there's a whole lot that we could do and be better at in regards to youth health. Cultural considerations was very important for us. So our manager had ensured that we had skilled, qualified staff who understood our community, could connect to the community, understood some of their ways of knowing, and that was important for us as a practice. Community-based resources that we had used, places like Wesley Mission, who helped us with elderly care, elderly abuse. Marae-based clinics was important for us, so we have an off-site clinic at a marae, and the mental health services and community law. And community law was to help our clients understand the importance of, what's the word, Simon? Community law for, someone give me the answer. When you want to sign up for, power of attorney. That was a big problem, and trying to explain that to our Pacific and refugee clients. Yeah. Thank you for helping me. I could see it in your face. Okay, so I'm going to hand it over to Simon, and he's going to do some case scenarios. 6 minutes.
Thanks, Joanna. In the previous speakers, they were talking about a train wreck. It's the same with our service as well, except ours is more of a tsunami of train wrecks. And that was before healthcare homes. And what healthcare homes has done for us is sort of enabled us to find ways to innovate, accommodate, and really have patient-focused care for the patients and addressing their needs. I'm just going to discuss just 2 cases of how we've been dealing with patients who are with chronic illnesses. Mrs. J.W., this was one of our most complex patients, 67-year-old Caucasian female, multiple comorbidities, large background of mental health, personality disorder, schizophrenia, bipolar, and the whole lot. And for years, we've been trying to get her engaged with other services such as mental health, social worker, but she wouldn't have a bar with it. And for years, we've been trying to get the Mental Health Act enabled upon her or action or sectioned upon her, but every time mental health would get involved, they would say, nope, she's fine, she has good insight, your problem, back to GP. And that was over a 6-month period. 3 times we said, and 3 times they said no. So afterwards we had the healthcare homes, MDT, our first MDT meeting, with the help of CDHB, with the nurses and social worker, and everyone else that was involved. Within a 3-month period, we were able to get her out of the home that she was living in and transfer her to a rest home, which was she really did need. And that was in 2017. Last year, she came back, totally different personality, smiling and coming into us to say, thank you. I'm a much better person. I know you tried to help me, but I had all of these problems left on me aboard. So that was one of the positive patients that we had. And she now has a boyfriend as well in the rest home, so that's an added bonus. Mr. T, 81-year-old, multiple comorbidities. The main issue and problem with him was that he lived alone. Poor literacy, didn't know how to write, didn't know how to spell. And unfortunately, he lived with a niece who was supposed to look after him. And this niece was drunken, and most of the times we'd come for home visits. There was no food in the fridge. And trying to get him to move into a placement was very difficult without the help of the MDT meetings. With the MDT meetings, we are able to collaborate and wrap around services around patients according to what they need. So in summary, given 30 seconds left, healthcare homes has been a huge bonus for us. And I think moving forward, I think we need to look at those families who are vulnerable, especially with families and children. I think that would be our next step. We're looking at the top 5% of vulnerability of those with elderlies and comorbidities and whatnot. But the next step would be children, families, and the rest. Thank you.